name's Carol Reed. I work in the Needham Public Health Department. I'm the director of the Needham Coalition for Youth Substance Abuse Prevention. And I am so very grateful to be here and have you all here. We work collectively as a coalition through the lens of the public health model, to decrease the risk factors that are known to be indicated in youth substance abuse and increase the protective factors. And prevention science shows that communities that have coalitions that engage all sectors, leaders, parents, faith-based people, law enforcement, school, local government, youth, they have lower youth substance use rates. So our goal is to decrease access and availability to substances. And I just want to let you know that we couldn't do this work without the collaboration of Chief Droney of the Needham Police and our leadership team, which I'd like to ask them to stand up. We have Bob Timmerman. Thank you, Bob. Karen Mullen, another dedicated parent. Mimi Stamer, the Director of School Health Nursing. Chris Baker, Lieutenant Chris Baker from the Police Department. And for many years we had Kathy Began, who's a parent and a pharmacist, and she's taken a little hiatus. And we have Karen Hood, who's a Needham parent, lifelong resident, and Merle Berman, who is the Pollard Assistant Principal. So we do our work with leaders in the community, parents, and we have a strong youth group here, Salsa and RAD. So I want to segue into the evening. Our goal as a leadership team in a coalition was to bring you the facts about what's happening in Norfolk County and communities. I live in Medfield. We participate in the same youth survey that Needham does. Our youth survey data is similar across 25 communities. Youth tell us how much marijuana they smoke in a month, how many different substances they might use. We have a lot of data, and I'm happy to share that with any of you, either after the meeting or through email or a conversation. And we've done that a number of times. So tonight our purpose is to bring you the leaders in the county and to tell us the realities of what's going on, as well as Dr. Kevin Hill from McLean Hospital. So I'm going to quickly ask Dr. Alex Wally to stand up. And just so you see, Dr. Wally, we're grateful here because we have so many residents who are willing to commit their time. We're going to hear about opiate dependence a little bit tonight, and our police department, we're at the forefront in the Commonwealth of having a medication disposal safe in our police department lobby over about 6 years ago. So we know about the epidemic of opiates and overdose. Dr. Wally is a Needham resident and a parent, and he's the director of the State Opioid Overdose Prevention Project. So he is going to be outside in the hall. He has resources to give people Narcan, nasal naloxone rescue kits. Many of you have heard of the success of the kits, that they reverse the impact of opiates, and it's a life-saving agent. People will tell you more about that. So Alex is going to step out in the hall, and if you would like to talk to him during the evening, please feel free, and you can come back and forth. Many communities have done that type of information service at their forums. So people, if you'd like some more information on that, or to get a rescue kit, they're available in Walgreens without a prescription to anyone. And they are covered by your insurance. There's more details on that you'll find at my back table as well as Alex. The last thing I'll say, in our health department, we're committed to be able to provide resources for substance abuse, referral, for treatment. We work with many providers here in and around Boston, and Dr. Hill is one of those advocates for us. we are able to give you mental health information. I partner with our public health nurse, Donna Carmichael, and we try to provide residents with a connection. Our goal, and many of us have addiction or mental health issues in our family, and what we're committed to in our department is to mitigate the stigma around substance abuse and mental health. And if you call us, we're confidential, and we'll do all we can to connect you, or family members, any age. So just make sure to take some of these resources. We're grateful because we had a federal funder for 5 years, and we have a ton of information. If you work in a school or a business and you'd like some of these resources, I can get you more. So I'm going to ask Jennifer Rowe to come up. Our program tonight is Jennifer Rowe works for District Attorney Michael Morrissey. And a few years ago in the county, he engaged people to come, please come forward, and work on prevention. So his goal is to have a substance abuse prevention coalition in each community. And Jen is, I told her she's my inspiration. She's an assistant district attorney and she's a parent. And she asked me not to say too much about her, but your school children are safer because of her. She runs school safety trainings and an amazing amount of programs to talk and bring these issues to the forefront to get many people equipped with the resources to have a safer county. So Jen's going to introduce this evening. Then we're going to have Deputy Chief John Carmichael, who's on the governor's opiate task force. And then we'll have Dr. Kevin Hill. I'm not going to talk after that. And please know that you can call me. My cards are back there. I'll give you my cell phone, but I'm at cread, R-E-A-D, at needhamma.gov, and I'm happy to give you my cell as well. So I appreciate you all being here, and just thank you for all you do and for supporting our work. Jennifer Rowe.
Thank you very much for inviting me to join you here tonight. I am pleased and very proud to be here on behalf of Norfolk District Attorney Michael Morrissey. And thank you for taking the time out of your busy lives to be here, and by doing so, recognizing the importance of the topic for tonight, and that's really protecting your families and your communities from substance abuse. As Carol mentioned, I've been a prosecutor in the Commonwealth of Massachusetts for about 20 years now, 21 actually. For the last 4 years, I've had the privilege of serving as the director of the Crime Prevention Unit in Norfolk County. And we strategize our resources and initiatives based on the causes of preventable death in Norfolk County. And for Needham and the 27 other communities that comprise Norfolk County, the two main causes of preventable death are both substance abuse related: impaired driving crashes and opiate overdose. So that's where we target most of our resources, and that's what I'm here to talk to you about tonight. In 2014 in Norfolk County, 37 people lost their lives in impaired driving crashes, and about 3 times that number sustained serious bodily injury in impaired driving crashes. We know that because of the extraordinary health care that we have locally, that many of those lives were saved because they were transported so quickly and treated so well in our area hospitals. In 2014, 91 people died of opiate overdose within our communities. That's up from 63 people in 2013. So in 2013, District Attorney Michael Morrissey applied for a federal grant to develop multidisciplinary, data-driven strategies to prevent opiate overdose. And 6 places in the United States were funded, 2 on the East Coast. 1 was Manhattan, and the other was Norfolk County. So if there's any question in your mind about how significant the problem is here, I can assure you that federal grant dollars are directed where the problems are the greatest, and unfortunately, the place where you're raising your families, where I'm raising my family, is one of those places. When I was preparing my remarks for you tonight, I was looking at some of your town websites for some statistics, and I actually stumbled upon an article that really struck me. And if you hadn't seen it, I wanted to read it for you. It's actually a letter of thanks from your fire chief following a recent incident. And it says the following: I would like to commend all who responded and supported the Needham Fire Department's effort at the 3-alarm fire this past Saturday night. It was through a team effort of not only Needham fire personnel, but also our surrounding communities who always come through when we need them most. Once again, companies were forced to deal with harsh weather-related conditions. Record snow depths, frigid temperatures, and a deep frost line coupled with a high water table worked against us. Incident Command should be applauded for recognizing a rapidly deteriorating situation. This early recognition led to striking additional alarms, calling in help from our neighbors. Responding to the fire were companies from Norwood, Boston, Dedham, Brookline, Westwood, Wellesley, and Newton. In addition, specialty units from Weston Air Supply, Dover Tanker were also instrumental in the response. In addition, fire chiefs and command staff from several of the responding communities lent their expertise to the operation. Even the Boston Sparks A-10 lent their support at the scene by providing food and drink for rehab of the responders. The Fallon ambulance ensured the safety of the remainder of the town while our forces were working is certainly not overlooked, and Needham Police and the Department of Public Works provided much-needed support at the scene as well. Further, the townspeople in the area should be praised for their efforts of making sure the hydrants in their neighborhood had been cleared prior to the incident. Their diligent snow shoveling over the past several weeks aided in the task of finding a hydrant that was operational despite the frozen ground. And if you're wondering what on earth that has to do with preventing substance abuse, and addiction and overdose death in your community, it actually has everything to do with it, because it's through those kinds of collaborations and multidisciplinary efforts from police and fire, from your surrounding communities, and from your families. The people who shoveled those hydrants are the people who will be safely disposing of their medicine and making sure that their families are educated about the responsibility of having opiates in your possession. And when you're done with that medicine and disposing it, and that's exactly how, as a community, you will make your families safer. My slide, I don't have a remote, so as I mentioned, there are two main causes of preventable death in Norfolk County. I'm going to briefly mention impaired driving, but I wanted to share with you some information that was self-reported by Needham students. Nearly 21% of Needham high school seniors reported binge drinking, defined as 5 or more drinks, on at least 3 occasions within the last 30 days at the time of this youth risk survey. And nearly 15% of Needham high school seniors reported that they were a passenger in a car with an impaired driver. As parents, those statistics should take our breath away. And what really surprises me about this, and I think what we need to learn from that, is that I think we're doing a better job in convincing our kids not to be the driver, but it's that second statistic, that they're willing to get into a car knowing that a driver is impaired. I mean, we're raising this generation of kids in an era of zero tolerance, and they have so much to lose, whether it's athletic consequences or consequences in school, that they might not want to be the driver, but they're perfectly willing to put themselves in harm's way by being a passenger. And I think when you first read that statistic, our first impression is to assume that we're talking about other kids their age being the driver. But what we believe is that much of that portion of reported statistic relates to kids talking about driving with their parents after they've consumed alcohol. So in response to that, we developed a project called the Hero Campaign. It's a partnership with a national organization designed to promote the use of a designated driver. So if you go into a pouring establishment in Norfolk County, you should look for the logo for the Hero Campaign. And if you identify yourself as the designated driver, someone who wants to get those that you're sharing a meal with home safely by not consuming alcohol, that restaurant or bar will offer you a free soda or coffee, and you can send a pretty strong message to your kids that you love them enough not to drink when you're out. So the balance of what I wanted to talk to you about tonight relates to opiate overdose and prescription medication. The photograph that you see up there is actually the launch date of our pharmacy outreach project in Norfolk County. Police and fire departments from across Norfolk County were invariably supportive of this. We had widespread and unanimous buy-in from all of our first responders, really to connect with our pharmacies, and there are 120 pharmacies in Norfolk County, 4 in your community, where we know that the opiates that are getting into the hands of our kids, that are beginning the struggle with addiction that often leads to heroin addiction, begins not in dark alleys, but in the pharmacies where we as consumers, as patients and parents, do our business. So because of some gaps in legislation in Massachusetts, specifically that pharmacists are not required to enroll in the prescription drug monitoring database, a system that can capture drug seeking and identify abuse of the dispensing of medicine through pharmacies, that we were determined to work together with our police departments to connect with pharmacists, get them enrolled in the PMP, and make sure that pharmacists know they can count on their police departments to respond to drug-seeking activity in their pharmacy. Pharmacists shouldn't have to factor in their personal safety when they're deciding whether or not to fill a prescription. I know we have a pharmacist here, at least one tonight, and that's the reality now. The prescription medication is just so valuable, and there are so many 24-hour pharmacies that this is definitely an issue and something that we're very mindful of. So we've talked about what we're doing in terms of pharmacies, but there's a lot that is going on in perhaps some ways that might not be as obvious to you as members of the community, but I'm sure you've heard a little bit about it in the newspaper, and Carol mentioned it earlier, and that's really the buy-in from every police and fire department in Norfolk County in equipping every cruiser, engine, and ladder with nasal naloxone. So the ability to save a life with nasal naloxone that's an opiate antagonist is obviously something that a police officer who's already out in a car, already on the street, can get there faster, doesn't have to get the boots on, doesn't have to get into an engine. We knew that that was working in Quincy, and we saw that the independent implementation in Stoughton had worked so well that DA Morrissey basically used that as a template and asked the police chiefs in Norfolk County whether they would be willing to train their staff. And it was a very proud moment for Norfolk County. Every department was in, and you have much to be proud of here. In 2014, there were 11 911 calls in your community requesting life-saving help for opiate overdose. And because of the choices made by Chief Droney and Chief Condon, your emergency responders are equipped with naloxone. And every one of those lives were saved in Needham. So congratulations on that. And I believe, Chief, year to date, you have 3 additional saves from the police department alone. That's just extraordinary. And to think that that was something that wasn't available as a life-saving tool just a year ago is really incredible. To think that police chiefs were willing to set aside bargaining and budget issues and just say this is the right thing to do was really a very proud moment for law enforcement. So as far as opportunities for you to protect your family, the main source for opiates for kids is medicine cabinets. And when I began as a prosecutor in Suffolk County 20 years ago, we were very concerned with saving young lives, but what was taking them was gun violence. And so the Massachusetts legislature enacted improper storage of firearms legislation, so that even if you had a license to carry, you still had to store it properly and maintain control over it. And you need to start thinking about prescription medication as that loaded firearm, because that's what's taking beautiful young lives here. And unfortunately, we haven't changed our thinking enough to do that. So I know that those of you who are here tonight are probably the ones who know about medicine return and who probably already know that there is a medicine return box in the Needham Police Department, and that medicine drop box is routinely emptied. That medicine's driven up to a clean energy company in Haverhill and incinerated, and that's done from departments across Norfolk County so regularly that close to 3 tons of medicine has been safely disposed of that would have otherwise been available for our kids to get their hands on. That's a really easy thing that you can do. The other is that we decide where we get our medicine, right? We decide, we're asked, where do you want to have your prescription called in? And as consumers and patients and parents, we can really change the way this works in our communities. We need to start asking our doctors, do you use the PMP before you write a prescription? We need to ask our pharmacists, do you check the PMP before you dispense a prescription for opiates or benzos? The kinds of things that, if taken in combination, or gabapentin, are what are taking so many lives in our communities. We have revised the way that we review overdose deaths in Norfolk County. Last week, we met with a designee from each police department, along with the DEA, the state police, both the homicide and narcotics side, as well as members of other regulatory agencies, the Board of Registration and Medicine and the Office of Public Protection that investigates pharmacies. And we were reviewing overdose deaths in Norfolk County from an 8-week period, and there were 32. And the trends that we see time and time again are that they, as a rule, most frequently men in their early 30s, that's the average age is 34 in Norfolk County, that many have been recently released from rehab, that where tolerance is lower and therefore more at risk for overdose, that so many are being prescribed opiates in combination with benzos, sometimes by the same prescriber, sometimes by different ones, often paying cash. And it's that access to large quantities of medication that, you know, when you look at the patient prescription history, knowing that this was someone who died of an overdose, it's staggering to see the amount of medicine that that individual had access to. So that's what we're doing as a county-wide office, but the real work and the real change can happen right at home by all of you. So take that medicine out of your homes and ask your care providers for your kids and for yourselves whether they're on board with the PMP, and if they're not, go somewhere else, and we can cause change in that way. So, yes, the PMP. The question was, what is the PMP? There's it's basically, it stands for the Prescription Drug Monitoring Program. It began in Massachusetts, I believe, in 1992. It's basically business records. So we're very good at paying and billing for medicine in Massachusetts. And there's one in every state in the country besides Missouri. So 49 states have this system that basically captures medicine into pharmacies and medicine out of pharmacies into the hands of patients, really for the purpose of billing. And so that system can also be used as a guide for doctors to see what their patients have access to. And there is a requirement that all doctors must enroll, and a requirement that a doctor check it when they see a patient for the first time. There's no requirement that a pharmacist enroll. So I think that I'm pushing the time limits here, so I want to thank you very much for including me, and thank you for recognizing the importance of this in your lives.
Thank you. Right now I'd like to ask Deputy Chief John Carmichael to come up. And Deputy Chief Carmichael started off in my hometown in Medfield as an officer, and now he is the Deputy Chief in Walpole. Yeah. But he is on the governor's task force for opiate overdose prevention. So he is here tonight to share some of his work and the realities of what he's dealing with on the local county level.
thanks to Chief Droney and Lieutenant Baker and Carol for having me in, and as well as the other, Jen, she's a huge advocate for us. And the DA's office, we're so lucky to have him. And, you know, I believe we're the only district attorney's office in the country that has a pharmacist that's actually assigned to his staff with Dave Morgan. And, you know, we're very fortunate, despite the problem that we're having, we are able to all network together through the DA's office. And I know a lot of you are from a coalition, and one of the things I think that we really need to do is start intertwining our coalitions and start networking together, and everybody get on the same page on how we're going to deal with this problem going forward. Because currently it is getting worse. You know, Massachusetts is targeted. In the past, we used to have the drug cartels down in South America that would push the heroin up to this area, knowing that we do have we're a regional area that does preference that drug. So, you know, that happened. They do target our area. Then recently, in the past 10 years or so, we started to have the Mexican cartels start to kind of join forces and also start to grow poppy down there and start to distribute and traffic heroin up here as well, which affected the price a little bit. And so, in addition to that, with the opiate pill problem, you know, we had a lot of people that were addicted to the pills, and then as an alternative, they were seeking these other drugs like heroin on the street. And as a result, we're seeing a lot of overdoses. We've become a source location now. Massachusetts, where we used to get our drugs trafficked up from New York and other large cities down south of us, we're becoming a source city. So what's happening is the heroin that's coming here isn't cut up as much. We're getting pure heroin, and some of the results that come back are upwards of 80 and 90% purity, and that's a scary thing when we compare it to years ago when we had about 60%. So it's a very potent drug that's being put out on the streets. Our overdoses in Massachusetts have gone up 1,000%. I mean, I'm sorry, 1,000%. About 90% over the past 10 years. And that's a scary thought. So just want to touch on a little bit on what we're seeing. And Needham, you're not immune. I mean, we're all, Norfolk County, Massachusetts, the entire Northeast region, we are all in this together. And this is very widespread. And for the governor to declare it an epidemic supports that. So absolutely, drugs, the drug problem, the OUI problem, as Jen mentioned, the ancillary crime that's associated with it that fuels all this addiction is the #1 problem, the #1 threat to our communities right now, hands down. So, you know, in policing, you've probably heard this a million times, we know that we can't arrest our way out of the problem. It's just not going to happen. But with that said, the criminal justice system cannot be taken out of the equation. You cannot have the criminal justice system not be involved in that mechanism. It's the #1 way where people actually get treatment in the country. So if you take away that mechanism altogether, the bottom's going to fall out, and it's going to cause a problem. We do need to look at other alternatives. People that do end up in the criminal justice system need to be diverted. The ones that want treatment, and we know that we can treat and help them in their recovery. There's a lot of different methods and things that are going to be done on the state. But sometimes, you know, incarceration is also a factor. And some people, it saves their life, believe it or not. Jen touched on reentry. We know that when people are released from jail or released from prison, or they just recently got out of a detox, that they're very susceptible to overdose. They come out, they go and they use what they used before, their tolerance isn't built up, and they overdose. One of the things that we did on the Governor's Opiate Task Force is now when certain people that meet criteria while they're incarcerated, they can get into these treatment programs while they're there through incentives, and then when they're released from jail, they're given the Vivitrol, the naltrexone, and which will help help them for about the first 30 days so that they don't just come out of jail, use what they used prior and overdose. And that's going to save lives. It's just another mechanism to save lives. So as far as the law enforcement, we totally understand at this point, and we're not 100% there yet, but we know that we're in a transformation right now. And I'll be honest with you, I've been on about 20 years. And Chief, I don't know, how long have you been on now, Chief? 21 years? No, 34. 34. So, and Lieutenant Baker will tell you the same thing. We remember the days of when cops looked at it as drug addicts, as junkies and punks, and that's how we looked at them. I mean, when I first came on the job, they were drug addicts and junkies, and that's how we looked at it. And our job was just to put them in jail and get them off the street, and that was it. Well, those days are gone. Those days are long gone. And now we have to take much more of a proactive approach. And in Walpole, and I know in Needham, I work in the Norfolk County Police Anti-Crime Task Force, NORPAC, which Needham is also a member of. We work with those guys every day. They understand it. Their job is to go after the drug dealers, but we do understand the issues with the people that are suffering from this disorder. It's a disease. It's a known disease. There's no cure for it. Police officers understand that now. That's why we have the Narcan and the cruises now to help save lives. We do a lot of other proactive things, like in my department. When we go to overdoses or that type of thing, we give them the helplineonline.com cards so that we can help them get into treatment. We give those to the family members. We do the drug take-back program. You guys have these at your station, the drug take-back program? Walpole Police Department last year, 25,000 people in town, we turned in over 500 pounds of pharmaceuticals that we collected from our drug take-back box. So then at some point I said to myself, that's great, but what's in there? Like, what are people turning in? Because if it's amphetamine salts or something, then who cares? What point are we serving? Well, we went through ours. We did random samples of our drug take-back box, and keeping confidentiality in mind, we went in and we emptied some of the pills out of the pill bottles, and we ran the numbers, and we logged all the numbers down, and we ran the numbers through drugs.com. And unbelievably, we came up with oxycodone, hydrocodone, benzodiazepines, muscle relaxants. All of the drugs that are killing people in Norfolk County are in that box, and significant numbers. I mean, the vast majority of the pills that we were finding in there are your drugs that are responsible for that. We call it the Trinity, the opiates mixed in with benzodiazepines and the muscle relaxants. And that's a good thing, because we know that at least that's making a difference. As Jen mentioned, how are these pills how are people getting their hands on these pills? Our kids are getting them from the medicine cabinet. I mean, everyone here has been to the dentist or broken a bone or done something like that, and you get overprescribed. You get all these medications that you may not need for that time period, and there's a lot of unused drugs. If we took in 500 pounds, and Needham probably took in 500 pounds, and all the other towns, imagine what's out there that's been used or that hasn't been turned in. So we know that's a problem. We know that overprescribing is a problem, and overprescribing of prescription narcotics is a problem. And as Jen mentioned, sometimes the physicians and the pharmacists don't recognize what we're seeing, and now we're sharing that information. In Norfolk County, we've gone to all of the pharmacists and we've said, look, D.A. Morrissey calls it the yellow flags. We give them a list of those yellow flags, and we say, this is dangerous. If you go into the PMP and you're seeing that you're prescribing hydrocodone, and then you're also prescribing alprazolam or one of the benzo drugs, and then maybe a muscle relaxant, or even the gabapentin, which is coming up at a lot of overdoses, we got to be aware of that, and we got to take action so that we can help prevent further overdoses out there. So with that said, you know, carrying Narcan in the cars, in the past 5 years, Walpole's had about over 50 overdoses total. About 14 of them were fatal. The rest of them, of the opiate overdoses that we have, 30 of them were administered Narcan, either by the fire department or now the police officers who have it in our cruiser. We're talking, potentially we could have had 44 fatal overdoses. And that's, to think of those numbers is just staggering. And this is every community is facing this, so. Crash scenes. We go to not fatal car accidents, we go to crash scenes now where someone's semi-conscious or almost unconscious, and we're not canning them and they're popping out of it. Like, we would have, as police officers, we would have never thought that over the years, that we would be carrying this drug and that we would be dealing with people hitting the pole, and the first thought in your mind is to give them Narcan. So, is it still a problem? General talk about stigma. Back to that the junkie comments. You know, this is a disease. We understand that now, and that there is no cure for, and that we need to use proactive ways to get people help, and that's what we're really striving to do out there. Would you be so as far as the opiate task force? It's almost been a year. March 27th of last year was when Governor Patrick declared the emergency. I was already part of the Interagency Council on Substance Abuse and Mental Health. Governor Patrick basically said, you guys are now the opiate task force. And he gave us 60 days to come up with all of these recommendations. And there's a lot of good things that are being done. One of them being the central navigation system. As police officers, we go to these calls, we deal with overdoses and people suffering, families suffering from drug abuse. And we've gone to them and tried to get them into helplineonline.com with VSAS. Get in there, and time and time again, we get the person that's suffering from this disorder that they want to get treatment. We can't get them a bed. There's nowhere for them to go. We've lost people in Walpole that were trying to get a bed that we were trying to help that overdosed in the interim. And that should never happen. Once somebody makes that decision, even with the Section 35s, we do those. It's involuntary. It's involuntary. It doesn't always work. Sometimes it does, but that's kind of what we're dealing with. And one of the things from the task force is the navigation system, where families or the addict themselves will be able to go into that navigation system. They'll be dealing with people one-on-one, and they're going to be given real-time inventory of the beds, the detox facilities, the treatment facilities that are there right now for them to go from point A to point B. And on our department, and I know you guys do it in Needham as well, we deal with the users, and we've driven them to rehab and brought them in, brought them right inside and got them in there. We've driven them to Rhode Island, we've driven them to Boston, Jamaica Plain, wherever we got to go, we'll take them. Once they make that decision, we're there to help them out. So that's a change. That's a change in how we used to respond to things. The drug courts, we have a lot more drug courts that are going to be starting out in Massachusetts. There's 14 right now. We have the recovery high schools that are going to go in. The naltrexone that's going to be given out. And then the addition to all the treatment and detox and facilities that have places for families so that the whole family can go, because what are you going to do? And I'll give you a prime example. If you saw the news article with the couple from Falmouth that went into Walmart and they stole a TV and the baby fell out of the car, we administered Narcan to that girl 2 days before that. And there's a situation where you have a little baby under 5 years old with two parents that have this issue, and where's the baby going to go? So there's families out there that need to be in a facility that can take care of a family, and that's out there. So safe prescribing is a big issue. Obviously, there's too much prescribing. We're opiate naive. We think that too much is better, and it's not. People are abusing it, and the overdose, and again, that's why we work with all the pharmacists as we go around and try and talk to them and get them to understand what we're seeing, and then they can kind of adjust that to what they deal with in the pharmacies and everything. So other things is grants out there. BSAS has done town meetings. There's peer services at the hospital, so when they go in there, there's a drug counselor that can help them out. So a lot of good things are being done. But my own personal perspective, I will say this before I walk away here, is this all starts, when you do risk management, you start at the beginning of the problem. You know, when people are dying, we're too late. We're a day late, a dollar short. So we have to deal with adolescents. This is when the problem starts. Working with kids and preventing their initiation to drugs in the first place. Delaying that age of onset. Talking about the adolescent brain. Getting kids to understand, get that perception of harm back up, that drugs are bad for you. You know, we're right now, we're in a generational forgetting of the hazards of drugs. And when we do that, that perception of harm goes down, and people suffer from it. It's empirical. You can look it up. That's the way it works. So we have to go back to our adolescence, prevention, and dealing with the prevention side of it, and stop people and help people so that they're not initiating to drugs in the first place, especially at an early age. And when we do that, I know Carol does. I mean, that is a tremendous job that you guys have done. That resource with all of the youth risk survey that you did. It's incredible. One of the things we found in Walpole was when we did our last youth risk survey, we measured for the kids' perception of harm on opiate pills versus heroin. Well, 85% of the kids thought that heroin had great risk. Only 50% thought that opiate pills did. Well, they're the pharmaceutical equivalent, right? So that's an educational thing that we can now go back into the schools and pump that into the kids, that the pills are the same thing as the heroin. They're derived from the same things, and therefore they're both bad for you. And try and use that as a teaching moment. But attitudes, behaviors, beliefs, when those things are diminished, we have drug problems. And to be honest with you, decriminalizing marijuana in 2008 and telling people no one's going to go to jail now, but what we did is we took that criminal justice mechanism away. The kids that used to go to drug treatment and drug education for having weed on them in 2008 don't have that anymore. None of them. Medical marijuana. Whatever your thoughts are on that, perception of harm is affected by it, right? And it's abused. The people that we're dealing with out on the street now having the dabs and the butane honey oil, pure THC is what's now getting into our kids' hands under the guise of medical marijuana. The dabs. So what they're doing now is because of medical marijuana, a lot of the things that they do is they convert the real plant material into THC, and they do that through a mechanism with butane oil, with butane gas, and they push it through a tube, and they actually extract and isolate the compounds from. It turns into liquid, like it looks like, and then it hardens, and they break it up and they smoke it. It's concentrated THC that's coming from the plant, and we're seeing that all over the place. And we're seeing that under the guise of medical marijuana.
Does it have an odor when you smoke it?
You can't smell it. Which is another thing, is police officers, we always ask kids, what does marijuana smell like? And they say rope, and it smells like marijuana. Weed smells like weed, and it's very distinct. The dabs don't really smell like anything, so it's very difficult to detect. A K9 probably wouldn't detect.
Kids getting this, the dabs too?
Yes.
Okay.
Yep.
So the kids in high school that may be smoking marijuana, they're having different ways to ingest marijuana. So that is why we perhaps are smelling it on them.
Correct.
Smelling it on their clothes, perhaps their eyes are bloodshot, blah, 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 blah.
Right.
Right. So this kind of information about the different ways of ingesting marijuana, especially the high school starting younger, this information I feel like is not getting out well fast enough with parents like some of us that maybe in high school that are really dealing daily with it, and our kids are researching online and finding all the unharmful data to support their belief that it's not harmful, and then they're doing it in ways that I'm not caught up on.
Right, yeah.
Right, and so it's scary right now, right now.
It is very scary, and it came in under the guise of medical marijuana. We didn't have dabs 3 years ago. Medical marijuana came on, and now we have people that are, there's no dispensaries yet, so they're growing their own marijuana, and they're extracting the compounds, and they're making this honey butane oil, and now you have, not only do we have kids smoking weed, we have kids smoking pure THC, which is good.
And other states that are ahead of us, there was an overdose in Colorado from someone taking care of these.
Yeah, yeah. But the point being is that attitudes, behaviors, and beliefs towards drugs have an effect on how we do things. And when we decriminalize, and now medical marijuana comes along, you know, the medical marijuana patient, 21 to 30 years of age with past drug use history, and minor self-prescribed ailments is the typical patient. And now we're talking about legalization in 2016.
But still not for high school age children.
Right, but the diversion, so that's my next point, is the diversion.
Yeah.
We have medical marijuana right now. A lot of them, people are growing it under the guise of medical marijuana and diverting it to kids. And that's precisely what's going to happen with legalization as it's happening with it. But that's a whole nother day, so.
So you can't smell it, doesn't impact their eyes, it doesn't impact, maybe the same effect as smoking weed, where it's a different kind of world, no doubt. How do you as a parent know?
In Walpole on Monday, we're doing a. Oh, I'm sorry. You can't hear me? Oh, I'm sorry. Okay, so you're wondering. Say again. I'm sorry.
So with this dab,
Yeah.
you can't smell it, and it doesn't make your eyes bloodshot, and
Right. How are you going to detect it?
how do you work with that?
So, right. How are you, as a parent, how are you going to detect this new drug this trend that's coming at us? Well, awareness. So the paraphernalia sometimes will tell you a lot. So same thing with marijuana. It has to come. They always have pipes. They have grinders. They have eye drops. There's a lot of equipment that kind of comes along with the use of most drugs. What we're finding in Walpole and in Norwood, we're seeing a lot out on Route 1 and stuff, is you'll see that they'll have the butane sticks, or they have the little tank of the butane gas, and they'll have tubes, and they'll even have the dabs, which look like honey. They're little. They harden it up and then they break it up in pieces, and it's distinct. It looks like chips of honey.
But if you find that, if you find that, is that what they're smoking? You know that you're smoking that little honey cube or whatever
Yep.
that is, and that's what you're.
Right. So they after they extract it and they harden it and they break it up and they smoke it.
And they smoke it,
Yep.
right? So you could find pieces of that, but you could theoretically not find all the paraphernalia because they could be fine that.
Right.
Right, okay, thanks.
Yeah. The way we've seen it, we've seen small bags of it. We've seen big bags and we've seen smaller bags where it's just chipped up, and it looks like little pieces of honey oil.
How prevalent is it in high school? I'm curious, was weed number one, then dab, then opiate, or what's the order in which?
Well, your gateway drugs are, I'm sure Needham, everywhere is pretty much the same. Your gateway drugs are the most available. So you're going to see marijuana, and you're going to see, obviously, alcohol. We're seeing pills now. In Walpole, we're dealing with Adderall. With the kids who have the ADHD, they get the Adderall, and the kids are sharing that and distributing that. It helps them, they say it helps them with their homework and do that kind of thing. So those are, we're not seeing a whole lot of opiates in our high schools. But back to risk management, That's why we got to prevent them from onset in the first place, is so they don't develop those patterns to use those things when they're 21 or 22. So, thank you.
Thank you, John. We're grateful, again, to have great resources, and again, our police officers here in Needham, which you're all welcome to come to our monthly coalition meetings. We meet the first Tuesday of every month, and Lieutenant Baker's there, Officer Springer is there, and we're a really casual group. Sometimes there's 20 people around the table. We meet in the Needham Public Library Community Room at 7:15 a.m. till 8:30, so you can come before work. And you can come at 7:45 if you'd like, but our own Needham Police Department is there every month and can answer questions like this for you, and we're grateful to them for that. So now we have Dr. Kevin Hill. Many of you may have been here a few years ago and heard Dr. Hill. He is a champion of mine, and he's a champion around the state. Another coalition or two are here. Many people have had Kevin speak to their communities. He works at McLean Hospital. He is an expert in addictions, and he is an assistant professor at Harvard Medical School. Most importantly to me, here in Needham, Kevin is a resource that I call or email to help Needham people. And I have to be truthful because he has a huge, busy schedule, and he always stops, and he will call Needham people back for us, for me. So I want to let you know that this is a person who's given a lot of time to our community, although you might not know him. So I'll let him talk. This is a setup for him. He will talk to you about a lot of different topics on brain development and the impact of substances on your adolescent. After, he's going to answer questions. Any of this information that you want, you can contact me. We're going to have Needham Channel make a great program, and you'll be able to see this again on television. But I'm really grateful. He's been patient. So, Kevin Hill.
Thank you. Thanks, Carol. I think you tried to give me a promotion there, which I appreciate. It's hard to come by where I work. So today we're going to talk about a lot of different things in a short amount of time. And as Carol mentioned, I'm happy to answer any questions that come up either today or at any point down the road. My email is there, so I'm happy to be a resource if at all possible. We're going to cover really drugs, so marijuana, opioids, and alcohol. Those are really the main things that we're going to talk about tonight and how they affect you. So to start it right off, I've got some good news and I've got some bad news. I think the good news is Needham is a great town, right? You've got great schools, you've got great people, you got tremendous resources from Norfolk County that you've heard about. So those are pluses. The bad news is you guys have these same problems that everybody else does. So I talk, all over the country, frankly, but mostly in the Commonwealth, and I know there are towns, great towns like Needham, where there are people that believe that, hey, these things don't happen here. We don't have these overdoses that we hear about. And we've heard today some of the numbers, but I'm going to reinforce that piece. So as bad as things get, the worst stuff that you hear, this happens in Needham, frankly. And that's why it's so important for people. And I commend you for coming out. There are a lot of choices that people can make. There are other events going on, certainly. But it's critical to learn. We heard the previous speaker talk about the importance of prevention. And that's really why I'm here. I think there's tremendous work that's being done, great research done at places like Boston Medical Center, McLean Hospital, but people don't know about it. And that's the problem. What good is it really if people don't know about it? So that's what I'm going to try to do in the time that I have. Also wanted to, in addition to thanking Carol for having me, I wanted to thank my funders. So the National Institute on Drug Abuse, a branch of the NIH, funds my research. And then also the Brain and Behavior Research Foundation, American Lung Association, Greater Boston Council on Alcoholism, and the Peter Dodge Foundation. So a bunch of people, fortunately, have supported my work, and certainly need as much support as I can get to do the things that I want to do, but I'm fortunate to have the people behind me who are behind me. So I do have a book on marijuana coming out shortly. A lot of the things that are in the book we're not going to get to talk about tonight, but what the book really focuses on is really the science. which we're going to talk about tonight. So what is the truth? You've got people that I respect on both sides of the marijuana debate. They have a lot of energy and affect and a lot of agendas, frankly, about marijuana. And so the problem is, I think, unfortunately at this point, a lot of the information that you hear is skewed. And so what I try to do when I talk in places like this in the book is to try to really present in a somewhat unbiased way what the data is. So we talk about the science, we talk about medical marijuana, the legalization of marijuana. What's the science behind those things? Can you do them effectively and limit risk? And then, of course, treatment, which is near and dear to my heart. What do you do if somebody's using marijuana on a daily basis? And we'll talk about that tonight, too. So what do? I'm a general psychiatrist and addiction psychiatrist. Most of the people that I see every day have addiction problems. So I deal with addiction essentially 24/7 in what I do. I've been at McLean since '09, and I've been funded by NIDA since 2011. It seems like a long time, although the grants don't last as long as I'd like them to. I see patients every single day. So the clinical trials that I conduct are patient-oriented clinical trials, developing medications. So we have 3 clinical trials that are ongoing now, 2 of them to develop medications for people that are trying to change the way they're using marijuana, right, and quit for the most part. And then I also have a smoking cessation trial. So if you're interested or people are interested in those trials, I'm always recruiting for those. And I see a variety of people who have marijuana problems in my practice. So people who do what I do see probably 40% alcohol, 40% opioids, 20% everything else. So I still see quite a few patients with alcohol problems, numerous patients with opioid problems. As we heard, it's an epidemic, certainly in the Commonwealth and around the country. And then I see a lot of people with marijuana problems, a lot of young people and older people too. And then people in special groups who tend to use a fair amount of marijuana. So I work a lot with athletes. You may have read that that's certainly an issue with a lot of professional athletes, marijuana. So certainly is a busy time for people that do what I do. But I wanted to have a few opportunities to try to get a feel for what people know about marijuana, because there are certain polarizing questions about it, certain beliefs that people have. And so there are powerful messages out there, and I think unfortunately some of those messages affect the way that most people think about marijuana. So this is akin to what I do. One of the things I didn't mention was I do a lot of work in schools. And so what I find is helpful, I'm a community partner to the Boston Public Schools, for example, and we have a goal of educating all 9th and 10th graders in the Boston Public Schools, primarily about marijuana, but also about alcohol and opioids, because those things affect high schoolers now, too. And so what I do is I ask them a lot of questions like this and try to get people to talk about what they believe, because that's critical, right? We heard a little bit before about the different kinds of marijuana that people are using. You have to know what's going on if you're going to have a chance to affect the outcomes in these populations. So you have to be up on this stuff, and the way to do it is to get people talking. So the first myth and fact, I just want a show of hands. Myth or fact? So marijuana is a plant. It's natural, so it must be safe. People who think that's a myth. All right. So most of the audience, we've got a good turnout. People think that's a fact. So marijuana is a plant. It's got to be safe. Anybody there? So, and I'm happy to certainly debate. That's one of the things. I mean, as I mentioned before, people who I respect have a variety of opinions about these issues. And so I'm always happy to talk about it. And I have to admit as well that my thoughts on some of these issues have evolved over time as I've learned more myself, as I've talked to more patients, as I've done more of this research. But clearly, importantly, marijuana is harmful. No question about it. There are differences between how harmful it can be for people who are young. So if you're 25 or below, your brain is still developing. So for those people, marijuana is especially dangerous for a variety of reasons. We'll talk about that. A little bit different once you're above 25, but clearly the message needs to be resounding to young people that it's harmful and we need to be careful about it. I want people to know what the data says. So there's several key factors that regular marijuana use can have problematic results for young people. Cognitive difficulties, clearly, affects the way you think. You can lose up to 8 points of IQ if you use marijuana regularly as a young person, and you don't get it back, unfortunately. One of the things that I see when people come in to get help for their marijuana use is that they feel that it treats anxiety. I was talking to a young woman today who said that, look, I get anxious a lot, and when I smoke, I feel less anxious. One of the issues with marijuana is that a lot of things about it are not intuitive. So that is actually true what she said. When you smoke, you feel less anxious. The problem is the effects of the drug wear off, right? So if you have a certain level of anxiety and you use marijuana or medicines that we're familiar with like Xanax or Valium, your anxiety level goes down. The effects eventually wear off and your level of anxiety seesaws back up. So you can use, and people try to keep doing this sort of thing, ultimately your baseline level of anxiety increases, which is why the data is quite clear that over the long haul, marijuana makes anxiety worse. So it's not something that you would use to treat this. And once you get people to try to understand these kind of ideas, it's easier for them to understand that, hey, this is something that I need to change if I'm going to address this problem that I have. Worsening mood, certainly, so worsening depression. Chronic marijuana use, daily marijuana use affects your mood. And then the last piece is kind of the scary thought that marijuana use among young people increases the likelihood that they'll develop a psychotic process like schizophrenia or bipolar disorder with psychotic features. So quite clearly, if you have a family history or genetic predisposition toward one of those illnesses and you use marijuana, you're more likely to express that. And that's pretty scary. That's been shown over and over again. Because so many people really don't know the extent of their family history, right? How many times have you heard, well, I think my aunt, she may have had a nervous breakdown, that sort of thing. So it's very difficult to know if you have a family history of a psychotic problem. So really, most people are at risk there, and that's been shown over and over again. Importantly, just a quick aside, this last paper, the DeForty paper, came out in Lancet Psychiatry just a few weeks ago out of Britain, and what it showed was the skunk marijuana in the UK was 5 times more likely to produce or to be associated with a psychotic process, a psychotic disorder. And what's interesting to me is that when they talk about skunk weed in the UK, they're talking about 13 to 17%. What's the average THC content in the United States? 13% or so. Last published data, it's probably a little higher. So it's interesting to me that in the United Kingdom, they talk specifically about high THC weed. That's just the normal stuff that you can get out here. So that's interesting. Marijuana versus alcohol. So this is one of the things that, you talk about how to relate to younger people. I think this is one of those pieces. I really believe that the relationship or the comparison between alcohol and marijuana is a great one, frankly. It's a great one. They're alike in many ways. The fact of the matter is, talk about credibility, the fact of the matter is that most people who use alcohol don't become addicted. The same's true with marijuana. Right? So as dangerous as it can be, and we've talked about that a little bit, we'll talk a little bit more about it, most people who use don't become addicted. Most people who use it like alcohol, and they're able to use it in however you would define a responsible way. The difference is the perception of risk, right? We talk, particularly now prom season is coming up, we talk about alcohol and we know that it's dangerous. We talk about ways to mitigate risk. We talk about designated drivers. When was the last time you heard anybody talk like that with marijuana? No, you don't hear that at all. So there's the difference. The President of the United States says that marijuana is not as bad as alcohol. Well, that statement may be true. Using alcohol once or on one occasion versus one occasion of using marijuana, that might be true. The problem is, in our country, where we want everything yesterday, where we jump to conclusions, and everything's black or white, yes or no, people think that, well, that's saying that marijuana is harmless. That's not the case. Just because something may not be as bad as something else, marijuana may not be as bad as alcohol, however you want to measure it, doesn't mean that it's not dangerous. So those are things that people kind of run past. They want to hear what they want to hear when people say things. But this comparison underscores the importance of being clear with kids. Right? People know that alcohol is dangerous, and yet, as we'll see with some of the data, I'll show you a graph, that people are hesitant to understand how dangerous marijuana can be for some people. Why is marijuana so complicated? I think the first thing, we talked a little bit about that a second ago. You can't paint it with a broad brush. So while I want you to take home some catchphrases, some buzzwords, a few stats, hopefully, tonight, keep this in mind. People that talk about marijuana, if they're talking in extremes all the time, they're probably not telling the truth, right? Because we don't know. A lot of the answers with marijuana are in the middle. There's a gray area. We're learning more and more about it. There's probably 60 or more cannabinoids or chemicals in the marijuana plant. We only talk about 2 of them. So we're learning more and more about it. So be careful. I think there are people that have agendas that want to oversimplify this matter, and that's not right. The second piece, people are misguided by their own experiences. So I can't tell you how many times I've had, it happens all the time, we just say that I have a kid come in using marijuana every day. We'll talk about a case in a little bit, where kids using marijuana for quite a period of time, the parents finally try to do something about it. They come in, they feel bad, they say, look, we knew that she was using in her room, smoking every night. We were hoping it was just the weekends. But we thought, well, it's not opioids, right? They're not using oxycodone. So maybe it's not as bad. And unfortunately, with the strength of marijuana that's available these days, it can be. A lot of times by the time somebody gets to me, it's often difficult to tell who's using opioids, who's using alcohol, who's using marijuana, because they can cause problems in multiple spheres of your life: work, school, relationships. The last piece, math can be tricky. I don't like to deal with large numbers if I don't have to, but with marijuana, we're talking pretty big numbers. So in the last year, about 19 million Americans used marijuana. That number is probably going to go up, I would guess. And so when you have to think about the absolute numbers of things, some of those people run into problems. Even if it's a small fraction of those people, a small fraction of a large number can be a very large number. So we're talking millions of people who are using marijuana in a problematic way. So this graph here comes from one of the important survey studies that's done every year, looking at young people and their use of drugs and then also perception of risk. We heard a little bit about data from Needham. I'll talk a little bit about that tonight as well. But this is monitoring the future data, comes out of the University of Michigan, and we're looking at use of marijuana among young people and their perception of risk. The green line shows how the use of marijuana is unlike the use of any other drug among this group. So cigarettes, for example, use is going way down. Alcohol, pretty steady. I like to say it's as dangerous as ever. But marijuana use is going up. Why is that? Well, I think we have an idea, right? The messages that we hear about it. Medical marijuana. If it's medical marijuana, how bad can it be? If it's legalized, it can't be that bad, right? So those are strong messages that you hear that we need to combat. And frankly, people like me need to do a better job of trying to educate people about what the actual truth is there. So the green line going up, the red line, perception of risk. So kids in the Needham schools, for example, what do they think about marijuana? Well, I can tell you, and I'm sure you know. I mean, I've talked to enough people, I've seen people from this town, and a lot of kids feel that it's easier to get marijuana than it is alcohol here. So they don't think it's a big deal. They're not alone, but importantly, one of the key messages from tonight is, while Needham isn't alone in how they approach some of these drugs, on the flip side of it, you're in it with everybody else. You got the same problems that everybody else does, and we need to do something about that. So when you look at this kind of graph, when I look at this graph and I see use going up, perception of risk on the decline relatively sharply, it's hard to imagine that things won't get worse before they get better, which is why we're motivated to try to educate people to change how they view these things. When people go into the voting booth in 2016 in Massachusetts and vote on legalization of marijuana, we just want them to be educated. Whatever decision they end up making, we just want them to be more educated about it. When we think about 2012 and medical marijuana, the reality is I've talked to enough people about this, and a lot of the decisions that were made were not as educated as they could have been. So another myth and fact, and some of you may think this one's easy, but let me tell you. So myth or fact, marijuana is addictive. How many people think it's addictive? How many not? So here's a story. When I go to multidisciplinary meetings, so when I meet with other healthcare professionals of various fields, and I tell them what I do and what my sort of specialty is, my niche, I will have other physicians, happens every year, multiple times, say, wait a minute, I didn't think marijuana was addictive. You know, and these are the people that are counseling other people about how to handle this. So importantly, and again, getting back to credibility, the fact of the matter is most people who use this drug don't become addicted. So if you're really in fear of marijuana use, you're worried about the problems associated with it, be careful about how you handle this. Because if you're trying to give the message that any marijuana use leads you to doom, well, people aren't going to believe you. They know better. Kids know better. Their friends have used, you know, people, their parents have used, and they turned out all right, right? That's the thought that people have. Many parents in communities like this use marijuana, and their kids know about it. And, you know, like it or not, they're role models, so it matters. It's about 9% of adults. So I mentioned earlier, 19 million users in the last year. When you think about a tenth of those people, 2-3 million. That's a lot of people. That's why, although we're always recruiting for our studies, we do pretty well when we try to get people who need help. The numbers for young people are worse, 17%. I would offer an educated guess that those numbers are going to go up because access to marijuana is on the rise. Certainly, you saw that in terms of use, but when you also think about medical marijuana, legalization of marijuana, access is on the rise. So those numbers are probably going to be on the rise. For people who have addiction, again, a chronic medical illness, it has a genetic component, so it's not their fault necessarily. They're not making choices. I don't want to, you know, they're not consciously choosing to mess up their lives and the lives of everyone around them. But they have a genetic piece that makes it hard for them to make decisions, not to use. So they have problems in work, school, and relationships. And like I said, if you're using marijuana daily for years, things can get pretty bad. And I hope people, by the time that I see them, it's not, all is not lost. And that's never the case, you know, all is not lost. But sometimes, you know, things have been going on for a while. It becomes difficult to dig out, so to speak. So yes, as I mentioned earlier, you have the same types of problems that you see with other hard drugs that people talk about. I like this slide here because it underscores the idea that things that we know are addictive. So on the top, stimulants like amphetamines, Adderall we heard about earlier, cocaine. You know, we know, everyone knows those things are addictive, right? Marijuana in the middle. Food, cheesecake, or I don't know if you've ever had the rosemary chicken and sweet basil. I mean, these things are addictive. So when something's addictive, in your brain, there's certain chemicals, neurotransmitters. Dopamine is one you may have heard of before. Pleasurable things cause release of dopamine in your brain. So the point here is that as you see that surge in dopamine with amphetamine, with food, the same thing happens with marijuana. So marijuana is more like things that we know are addictive than not. All right? It's not going to kill you probably like opioids can, but things can be bad. It's certainly addictive. There's no question about it for a subset of people. Yes?
For the medications like the Concerta and the Adderall and the Ritalin, there used to be case studies, I believe, that show that when kids were prescribed these medications, that their use of illicit medications decreased. I think the theory being that they were not self-medicating themselves with drugs that were not prescribed to them. And I was wondering if that is still the case or if you actually see an increase in addiction behavior among kids who have taken the...
No, you know, I'm not familiar with that data, but I will say this, because again, another thing that I was dealing with today in a young person who had a substance abuse problem, the question of whether or not they should take Adderall. We were asked this question on a patient at our hospital. And to me, the first question is, do they have ADHD? Right? So how do you make that diagnosis? There's a lot to it. Often involves neuropsychological testing. My thing is, if you have addiction problems, I don't necessarily say that there's an absolute circumstance where you would never use a stimulant like Adderall or a medicine like a benzodiazepine. But you have to be very careful. What is the diagnosis there? If they really have the issue, so what you were saying, I think if somebody really has ADHD and they weren't being treated appropriately, they're probably more likely to use drugs of abuse. If you're treating a problem appropriately, probably less of a reason to use, I would say. So certainly, again, with marijuana, consequences are quite clear. There can be problems in school, athletic performance, artistic performance. Another kind of getting back to what I think motivates kids, it's the short-term, more tangible consequences. While I want every student that I talk to know about some of this data, I'm not naive. I know that, oh, wait a minute, you could lose 8 points in IQ? Okay, I'm not gonna smoke tonight. Well, that doesn't happen. But what happens is, if they fear that they're gonna lose something they want, I wanna play in the sectional game in 2 weeks. I wanna go to Dartmouth. If there's something they feel they're gonna lose, that changes the behavior. I got suspended. Uh-oh, I got a problem now. Like, those are the things that will stir the kind of behavioral change that people are looking for. I do want people to be educated about it, but I'm not, again, it's the short-term consequences that are gonna change behavior. Fine motor problems, driving issues, again, which I think is a critical issue as we consider increasing access to marijuana in the Commonwealth. We simply do not have the 0.08 blood alcohol content equivalent of marijuana. We don't have the technology to test for it. So that's an issue. When you had mentioned, somebody had mentioned earlier about people saying, look, we know people that smoke and do well. Yes, it does happen. It can happen, absolutely. Ultimately, what happens for a lot of people, though, who use marijuana regularly, if they're using, again, daily or nearly every day, the question becomes, are they really reaching their potential? So with athletes that we work with, for example, super athletes in high school, it doesn't really matter. They can go to Division I in the best leagues, and it doesn't really matter. But once you move up, when you're facing other people who are extremely talented in whatever it is that you're doing, let's say your school performance or whatever, the margin for error goes down. And then people start asking the question, wait a minute, maybe this is not congruent with where I want to go. So it's a subtle thing. It makes it harder to find out, right? I mean, you're not going to knock off a CVS to try to get marijuana. So there are more subtle issues that come into play. But we'll talk about that. So let's move on. Let's talk about alcohol. As I mentioned earlier, alcohol use has been pretty steady for the most part. So still a major, major problem. Sadly, every year, really throughout the year, there are numerous one-car accidents or accidents involving alcohol in young people. So it's something that we have not been able to shake. So myth and fact, majority of teenagers binge drink. Myth? People paying attention here? Good. Fact, majority of binge drinking takes place. So actually that's a myth. So one of the things that we do when we talk to young people is we try to help them understand, while there's a lot of attraction to this kind of party lifestyle, like people who are going to parties and smoking marijuana or drinking, that sort of thing. Everyone, that's why people watch the Kardashians, right? You wonder, well, maybe somebody else's life is more exciting than mine, right? That sort of thing. But we want them to know that actually kids like you who don't drink, that's the norm. Binge drinking is not the norm. So as you can see here, it's about 22% of seniors and 14% of sophomores binge drink. So it does happen, and it happens in communities like this, but it is not the norm. Another myth fact, teen drinking and driving has increased past 20 years. Myth? Okay, you're doing really well, I have to say. Fact, on the increase. So hopefully, people are learning a few things. Actually on the decline. Why is this important? Beside the fact that it's good that these numbers are on the decline, but I think it also underscores this idea that for some substances that we've chosen to legalize, we actually are doing a decent job of educating about, right? So again, as I said, use of nicotine among young people is on the decline. People know that it's not a good thing. The smokers that I see in our studies, they're not saying, look, I want to keep doing this, but I should stop. They recognize that it's not good for them. And I think the same message is here. Alcohol has certain appeal, clearly, but people know it's dangerous. So the message is a bit different with marijuana, and that's why we need to do a better job of educating people about what the truth is. Opioids. So opioids like heroin are more addictive than alcohol and cocaine. How many people think that's a myth? Fact. Some people just aren't, they're not. Be brave, it's fine. They're not recording the audience responses, I don't think. Heroin certainly is more addictive. this is why, really, for any opioid at all, I was saying this yesterday to another group, that any opioid use, you need to be very careful. So I remember my mother had a knee operation a couple of years back. And those are things that you have to be careful, because if you're talking about essentially a quarter of all users, people who touch opioids, I actually think those numbers are probably low. I mean, I think anecdotally, I would guess they'd be a bit higher. But if you think about that, if the published data says about 1 in 4 people who touch opioids are going to become addicted to them or develop a problem, so any opioid use, you need to really rethink that. Do they really need this? And again, you get into issues of, well, how many, how long should that script be, et cetera, et cetera. But the point is, among the illicit substances that we commonly talk about, heroin's the most addictive, yes? Yes, so when we talk about opioids, they're prescription opioids, Vicodin, oxycodone, Percocet that you hear about. Those are the prescription opioids we talk about. And then certainly heroin is the illicit form. There are other opioids, fentanyl, things like that, but really the ones that we talk about prescription opioids, which are often a gateway or an entree into heroin. Yes? Addictive. So when I talk about a simple definition of addiction is repeated use despite harm. So there are many criteria for it, but more or less, you continue to do something that's harmful despite the fact that, oftentimes you recognize that it's harmful. So you're spending all of your time trying to get opioids. You're doing that, you're seeking opioids, or you're using instead of going to your kid's soccer game, et cetera, that sort of thing. So you're making bad choices because you'd rather, frankly, be high or try to get high. So this headline here, I think, illustrates quite nicely the fact that we are in an epidemic, certainly in the Commonwealth. This is from Tuesday, actually. Heroin overdoses kill 3 in Lynn. So this is not an unusual headline. If you pay, not many people read the Globe anymore for a variety of reasons, but if you do pay attention to the news, I mean, these overdoses occur quite frequently. And again, if you think that they only happen in places like Lynn, you're wrong. Again, we talk about the data, and the data says otherwise. We'll talk about what that is. Heroin deaths have been surging lately. So you've heard more and more about it, primarily because people have been dying. So essentially flat line mostly until about 2008, and then a recent surge. That's why people are interested. I think, again, there's that wow factor to it that people die, and they can die in very dramatic ways. But there's no question about it. The deaths are on the upswing, and people are interested in it, obviously. Current governor, the last governor, even the president has pledged some money towards this. Importantly, heroin is affecting younger and younger people. This is kind of news. This is sort of a newer piece. So as you can see, when you look at the data, that 18 to 44 demographic is really where a lot of this is taking place. However, we're talking about youth today, and certainly people in that demographic are young. But when you think about Needham, for example, so in the 2012 data from Needham, we have a sample size of 1,400 and change kids in Needham High. There were 30, essentially, kids that had used heroin. That's a lot. Actually, would fill this room. As many of you out there, we could fill the same seats with kids using heroin. The problem is, when you're using heroin, I mean, you're upping the ante, right? This is a deadly, deadly drug. Think about that. I mean, that is pretty shocking, right? So as much as people want to say, hey, in the Metro West, we don't have these problems, there's the data for you. It happens here. We heard earlier about the use of Narcan here and that availability, which is tremendous. Obviously, we've made a great deal of progress. But the fact of the matter is we have a lot of people using heroin, and those people are younger than we'd like to think. Why are these overdoses on the rise? Well, there are a variety of ideas about this. Certainly this idea of using prescription opioids for pain, so prescription like Vicodin, Percocet, et cetera. The year 2000, people were talking about this idea where pain was the 5th vital sign. Are you treating pain appropriately? I think then there was a belief that you could treat someone's pain to zero. I think that's less of an issue now. But when you have that kind of notion, plus companies that are making a lot of money selling pills, well, there were a lot of sales of these prescription opioids at that point. They've somewhat flatlined a bit. So people transition quite frequently from prescription opioids to heroin for a variety of reasons. A couple of them are the fact that finally, after several years, there have been more development of tamper-resistant forms of these pills, so gummy forms of oxycodone, for example, that people cannot inject or snort as readily as they could before. And then the always prevalent idea of price. So if you're using Vicodin, let's say, Vicodin's your drug of choice, and you start using that and you run out of your script, you start buying it on the street here, it's about $1 a milligram or so. Ultimately, you're going to run out of money. You might steal or do something to try to finance that habit for a while, but eventually people are forced to choose between, am I going to go into withdrawal, be dope sick, or am I going to buy some bags of heroin? And that's why that happens. Heroin is certainly stronger now than it was before, and it's often cut with powerful additives like other opioids. Fentanyl is extremely strong opioid that sometimes is added to heroin. And the reality is, for people that are using opioids, they want the strongest stuff. If they heard, wait a minute, there's a bunch of overdoses in this town, maybe the batch is there, they're going to go there. So that's actually a selling point. And then the last piece here is that there is a relationship between marijuana and opioids. We're learning more and more about it. And as more marijuana becomes available legitimately in the United States, the cartels say, wait a minute, I'm not going to make as much money selling marijuana, so we're going to sell more heroin. A couple other things just want to throw out there. I think people, and I'm happy to talk about other forms of marijuana as well, but just other things that people are interested in. First of all, the e-cigarettes. So that's been a real issue in many towns that I've been to. The canisters, so they're electronic devices with canisters of drugs. So it could be nicotine, could be THC, frankly, could be almost anything. But these things can be very strong. A person who has not used these products before may get a strength of nicotine that they're not used to, and that can be dangerous. They certainly can be addictive like regular cigarettes. So something to know about, and again, it's become more and more of an issue among young people. The edible products, we heard earlier about the butane hash oil, dabs, shatter, that sort of thing. I'm happy to answer questions, but the edible marijuana products have been something that I think a bit more prevalent lately, simply because of there are 4 states right now in the district that have legalized marijuana, 23 states and the district that have medical marijuana. So these edible products are out there. And so the science behind them is somewhat complicated, frankly. Number one, certainly young people can gain access to these. They often packaged, as you can see, like candy, so they can be appealing to young people. Another piece, even if for people who are intending to use them, is this idea that the onset of action is much slower than when you're smoking marijuana. So what happens is a story I've heard many times, people taking a chunk of an edible product, wait a minute, I don't feel anything, I'm gonna take a little bit more, still nothing, take a little bit more, and then boom. What they've done, they've built up a pretty high concentration of THC, and it hits them all at once, and that's how there was you may have read in the New York Times and things like that, a lot of people have had that sort of experience, so it's dangerous in that way. Let's talk about treatment. So what to do, I know people had asked a little bit, what do you do? What do you look for? And then if you find something, what should happen? So a case here, this is a very, very typical case. I changed some of the information, but I've seen it happen many, many times, including this week. So Johnny, 16-year-old high school sophomore, no previous addiction history. Never seen a psychiatrist before. Suspended, selling marijuana. So that was the entree into all of this, was actually selling marijuana. It wasn't that somebody was saying, wait a minute, he's smoking every day, so he got caught selling. That was his first way to get on the radar. Upon talking with him about it, smoking 4 or 5 times a day with friends. Everybody at my school smokes, and a lot of people deal, is what he said. So he has been going on for 2 years. And the core of the issue was really probably not the marijuana itself. It was this idea that in his affluent community, like where we are tonight, he decided, look, I'd rather be messed up. That wasn't his word, but I'd rather be messed up. That's really where the core of the treatment came to. Why is it that you would choose not to be you on a given night? Saturday night, you're not doing work. I mean, places like Needham, tons of homework, for example. You're going to let loose a little bit on Saturday. Why is it on a night like that, being used not good enough? This kind of, again, when you talk about treatment, why is treatment so important? Why is it so critical to understand the timelines here and to do things and to put all hands on deck when you can? This is a paper that we published at McLean a couple years back in Journal of Substance Abuse. And really what we did in this study, we have an adolescent treatment unit. We did a survey, several hundred kids there. And what we found among people in treatment was really two things that surprised me, frankly. Number one, sporadic marijuana use, getting introduced to marijuana. Sporadic use can become daily use very, very quickly. So it doesn't take years. It can happen very, very quickly. And what was kind of shocking to me is that marijuana use can move on to harder drugs very, very quickly as well. And why I think this was shocking to me is because, I do work still occasionally on the detox units, and so I've seen a lot of young people in the past, 20-year-old, come in using Perk 30s. Never been in treatment before, been doing this for a few months. Fortunately, somebody figured something out, they're in treatment. I used to believe, like, okay, this person just getting into treatment, we're going to call their parents, we're going to educate them. We've got some time on our hands, right? If they're going to move on to heroin, we've got at least 6 months, probably longer. I was naive. Stuff can happen just like that. As we talked about, the numbers here, the money involved is tough for people to handle. 20-year-old kid, you're spending over $100 a day. How long is that going to last? So that choice about, I stole as much as I could steal, but I can buy a bag of heroin for $10. That choice comes very quickly for a lot of people. The point is, from our study and others, we're not the only one doing this kind of stuff, is that any drug use among youth needs to be treated with as many resources as possible. So you find that glass pipe, you got to bring the cavalry at that point. If they may not be addicted, they probably are not if we looked at the data, but you still need to make sure. I'd rather do everything we can, look at this in every way, have the conversations that we're going to talk about, and find out that this is something they are doing occasionally, than to miss an opportunity to get somebody into treatment that they need. Yes? Using marijuana. Somebody using marijuana. So marijuana paraphernalia. What do you look for? I think the biggest thing, so this is a question that comes up really with all, I mentioned the sports thing. People talk about teams, what do we look for our athletes? Same thing, like kids, all different groups, but it's really the same sort of thing. To me, the biggest thing is you got to know who you're thinking about here. In this case, the kids. You got to know them. What is their routine? So, if a kid been playing soccer since second grade, and now they're a sophomore and not playing anymore, why? You got to find that out. There may not be much to it, but there probably is. That's an opportunity here. So the loss of routine, I think, is key. Somebody could have obvious problems. I mentioned the kid, Johnny, got suspended. So that, okay, we got that one. That one's not hard to figure out. But giving up important activities. But you have to know the activities. You have to know what's important a lot of these times. And sometimes it's not so obvious, but you have to have your ear to the ground. You have to have that rapport. We'll talk about that. Use in dangerous situations. A lot of young kids that I see in their teens using marijuana either are getting suspended or they're running into law enforcement, kids in the car with marijuana, maybe getting a chance to get some treatment, that sort of thing. That happens a lot. So use in dangerous situations. And then use despite obvious problems. So somebody could come in getting treatment for anxiety when you take a careful history. Well, why? They're trying to medicate this anxiety in other ways. We haven't gotten to medication. They haven't had any treatment before. They're doing some other things. So there are obvious problems they had. They may not think that the drug use is a problem. I've seen that many, many times, right? Marijuana is not a problem. My problem is really depression. I want to do something about that. I can still smoke every day. That's where education comes in. But that happens. So they're using, despite these obvious issues, where they even think they need to do something about these issues. So that's still great, because you get a chance to build an alliance with them and help them make the changes they have to make. So if you decide that somebody may be using it in a problematic way and you're thinking about doing something about it, how do you have that conversation? Something I've been thinking about quite a lot lately, and this is in my book too as well. Really 4 things: preparation, conversation, and then after the conversation, evaluation and referral. So preparation, the most important thing here is having that rapport. You got to talk to kids in a meaningful way. So hopefully your kids you're talking to in a meaningful way. Again, you know, I talk to people like you all the time. There are great people who spend their whole day now like in their iPhone, and kids recognize that. You know, that's talking to enough kids. Look, my parents are interested in other stuff. They got their own things going on. So you have to be involved with your kid. Talk to your child. Obviously, they're not going to want to talk to you on your timeline. A lot of times you're bugging them. Leave me alone. But the point is, when you're asking those questions, they recognize that they're interested in what I'm doing. And so when something goes down, something bad happens, they're going to be able to talk to you. And as I mentioned earlier, similarly, that relationship, what you do, you're preparing, you're preventing. If they know how you feel about marijuana or alcohol or whatever, when they have an opportunity to make a decision with their friends, that matters, right? So if they know you smoke in the house, marijuana, I'm not talking about cigarettes here, bad enough, but it's hard, right? It's hard for them. If you're telling them, hey, look, this is a problem, but yet they know you do it, you're going to have difficulty there. If you're going to have that conversation, you got to have an idea of what you want to say. Because the window is small a lot of times, so you have to be ready to jump through it. And have a plan. If they say yes, what are you going to do? Who are you going to have them see? Where would they go? If they say no, how are you going to handle that? Are you going to force somebody, push them into an office with somebody like me? Or are you going to say, look, okay, we're going to try it your way for a limited period of time. If something else happens, though, then we got to do it my way. And you have a little bit of leeway there, particularly with minors. What is that conversation? Again, as I mentioned earlier, what they really care about is short-term stuff that matters to them. Often sports, often going to college. Could be, I want to be able to hang with certain friends, that sort of thing. Those are the things that matter to them, and they want to preserve. That's going to get them to do things that they might need to do. Importantly, really the conversation comes down to really one thing for me. As a parent, as a teacher, or whatever it is, say, look, I'm worried about you. I think you need an evaluation. That's all you have to do. I can be the bad guy as a doc and tell them that, look, I think you got a problem. We got to get some help. Just let's go in and talk to somebody. You know, you can say, look, I'm not an expert, but let's have you go talk to somebody who does this every day, and they'll tell us what we need to do. There are times when, you know, it doesn't rise to the level of somebody needing to go into a treatment program, for example. But I'd rather make that determination than miss out. Evaluation, again, never worry alone. I say this almost every time I talk. You don't have to have the answers. It's unreasonable to expect everybody to know all these things and what they should do. What does a treatment program look like? How do I get in? I mean, that's ridiculous. But you do have to know where to get the answers. So don't worry alone. A lot of people want to help you. The coalition here, your primary care doctor, obviously specialists sometimes. Ultimately, you just want to have that young person who may have a problem talk to somebody who knows about addiction. I'm less concerned with what the initials are after the name, that sort of thing, but they got to know what they're doing. Unfortunately, just my opinion, obviously, but the bar is pretty low in mental health, I think. A lot of variability. The bar is unfortunately kind of low, so you may have one chance to get that evaluation. If somebody you send them to doesn't really know what they're doing, or we might have a problem. And then what does that evaluation look like? For me, it's a conversation. So what I like to do, if it's a young person, I like to have them come in. I'll talk to them 45 minutes or so. I always want the parents to come too. Bring the parents in for another half hour or whatever, just so we're clear on what my recommendations are. In that talk with the kid, what I try to do is what's called MI, motivational interviewing. My definition of that, kind of an easy boiled down version, is really them telling me one reason why they want to change their marijuana use or drug use or whatever it is more important than me telling them 10 reasons why they should change. So just tell me one thing where this could be a problem. And again, we talked earlier what those things usually are. But that's what we're trying to do. Once you do that, you build on it. And when you spend 45 minutes listening to somebody, I got news for you. It doesn't happen much these days. So when you do that, when you're asking the right questions, you really do two things. Number one, you say, I'm interested in you, I care about what happens to you. And number two, if you ask the right questions, they say, well, this person actually knows a few things about this issue. So we make recommendations about what should happen. Very frequently, people don't want to do what I think they should do, and that's okay. It's part of the illness, really. But I want to be crystal clear about it. That's why I have the parents come in, and so we're all on the same page. Look, I think you need to go into a program, an intensive outpatient program, which is usually 3 days a week, 3 hours at a time, 9 hours or so, plus some therapy. We'll talk about that a little bit. But I want everybody to know what I think should happen. What happens a lot of times, people will say, well, I know our child doesn't want to do that, and we're willing to give them a shot. They don't think they need to do it, we'll give them a shot, and that's fine. Ultimately, people call back a lot of times and say, wait, do you remember us? We were in your office, and I'm just like, sure, let's go, let's do it. Referral, what happens? Different levels of care, but generally most of the treatment is on an outpatient basis. So you hear about residential programs. You may have seen intervention where at the end of the show, if somebody wants treatment, they hop on a plane, they go out to California for 90 days. That doesn't happen very often, unless you have a tremendous amount of financial resources, but it can happen. Structured outpatient programs are what most people need. If you've got a problem, it's a long-standing problem, you've got significant issues, you may not have had treatment before, but you've got significant issues, you usually go into a structured outpatient program. Outpatient therapy is generally just talking to somebody. I had a young person say to me the other day, I don't like therapy. I saw a therapist before. It didn't work. There's nothing that anybody could say to me that would change what I do. And I just said, well, that's actually not what therapy is about. It's not about me telling you what to do. It's not about me giving advice. It's about me helping you examine your own life. Why are you doing these things? Why do you need to be messed up? Choosing to do that instead of other things. That's what therapy is. Groups can be helpful. Sometimes you have groups that meet every week, certain people where you can do AA, NA. There's also Marijuana Anonymous. So those things can be helpful. Treatment, again, a detox. So we're talking about not just marijuana here, obviously. A detox may be necessary for alcohol, for example. Other than alcohol, it's hard to get a detox approved. You can get it for opioids, not all the time. But a detox may not be necessary. This going somewhere for 30 days, again, doesn't happen a whole heck of a lot. But in the early going, we're just trying to get somebody to talk to somebody about this issue so that you recognize, well, somebody else besides your mom is telling you this is a problem. That matters, right? It makes a difference. And then in that session, you want to build this alliance. So we call it readiness work. But again, as much as I do trials, I do clinical trials of medications, also of these kind of talk therapies. What I have to offer more than anything else, and this is what I teach the doctors that work under me, is that the alliance is the biggest thing that you've got. If they know that you care about them, that matters the most. They don't know necessarily how these things work, but generally, they don't care what you know until they know that you care. The case, again, this person, the typical person, the person started weekly talk therapy begrudgingly with the understanding that if just seeing a therapist alone, if that didn't work, if they continue to use, then you would go into a structured program. But that didn't happen in this case, at least not yet. So again, this is a chronic problem. It doesn't ever go away. You can manage it. But if you really rise to the level of needing to see somebody, then you've got a chronic medical illness, and it needs to be managed. So final thoughts, again, you guys are ahead of the game just by being here, being aware of these kind of issues, trying to learn more about it. Communication, can't say enough about that. So not only among your own family to try to understand when there may be a problem, but also communicating with other people in case you might need help. Be able to ask for help. That's critical. I do it myself all the time. Certain things that I feel less comfortable with, and I know who I'm going to call about those issues. So never worry alone. And then the last thing, which I think is especially important with opioids, because people are dying out there, and it often seems hopeless when you see people dying every day, frankly, is that even for the worst heroin addiction, treatment can work. I mean, I've seen it happen. People that you would never expect to do well can do well. So you never do know, you should never, ever lose hope. This can always work. So I'm happy to take questions. That's my Twitter feed. What I do, again, when you have a lot of people with various interests spinning data, I try to interpret the data in the way that I see it in a somewhat unbiased way. So I'm happy to take more questions. I know it's running a little bit late, but I'll be here. I'll take questions, and I'll be up here for a while. Yes?
Is parental control of the youngster's discretionary income important to keep them off drugs? Nobody's standing on the corner giving it out.
Yeah, no, it makes a difference. So really so we talked about opioids, very expensive. One of the things that I think people underappreciate is the idea that marijuana is actually pretty expensive. So an ounce of high-grade marijuana, $300-400. Kids don't buy ounces. They buy smaller amounts, so they're actually getting less of a value, if you will. And as I would say, when I was a kid, being a teenager, $20 was a lot, to have at any point, if I was going to buy baseball cards or something. So to finance a marijuana habit or any other drug habit takes quite a bit of money. And what happens is, as I've heard from many of my patients, is that they're asking for a significant amount of money every day from their parents. And at some point, the light has to go on there. So yes, you need to be aware of how much money is going in your kid's head and what they're doing with it. But that kind of gets to this idea that you just have to have that conversation with them about what's going on, ask them. So it does make a difference. Absolutely. Yes?
It seems from the statistics that you showed that there are, if I'm understanding correctly, there are some people that do not have a genetic predisposition for addiction that get addicted anyway.
Yes.
And I know that there's an idea that's very different from what you were talking about, that it's not the substance, it's the abuser. But it seems as if that's not entirely true, given what you talked about, that there are some substances that are more overwhelming to a person's system than others. So I'm wondering what role that genetic predisposition plays.
Well, a couple things. I think, so the question was, is it the person or is it the substance, more or less? It's complicated. There are a lot of factors in there. Definitely the substance matters. There's certain things, if I'm 13, when you're 13 years old, if you're going to do something, you're going to do usually nicotine, alcohol, or marijuana. But beyond that, a young person in high school, those 30 kids in Needham who are using heroin, I'm really worried about that, right? So yes, it does make a difference. That is a more addictive substance. You're more likely to run into problems with that. The genetic piece, we don't know enough about it. We know that the heritability of addiction, more or less, a variety of addictions, is around 50%, just as it is with asthma, diabetes, high blood pressure. So again, it's a chronic medical illness like these things that we accept. But we don't know enough about particular, we know a few genetic polymorphisms, as they say, genetic pieces associated with alcohol dependence and that sort of thing, but for like marijuana addiction, we don't have a particular, so we're learning. The game is changing in many ways. I would say that you're right. There are a variety of factors that are in play. Genetics are strong. Certainly, if you have a history of addiction, you got to be careful. You may not be able to do the things that your friends do on a Saturday night, so you have to be careful. But similarly, the environment, what you're exposed to, plays a role as well. There are studies of twins that kind of show that sort of thing as well. So it's multifactorial, as they say, many factors. Yes?
I'm from Concord, Carlisle. And one of the things that we're struggling with are sort of the social norms, the myth and perception. Our risk behavior survey showed very similar numbers, that feeling that everyone's doing it, and particularly when you look at these social media sites, a lot of the kids who are engaging in these high-risk behaviors are dominating the conversation and giving the perception that everyone's drunk on Friday night and everyone's having sex, those kinds of behaviors. So have you looked at the social media component to addiction?
I have not, but I think conceptually it's entirely feasible. Again, when you talk about people like me doing what we're doing, you got this amount, and then you've got everything else, where kids are getting their news, generally social media, things like that. They're not watching, they're not reading the newspaper, that sort of thing, but they're getting information at a high volume and a high density, and compared to what we're doing or not doing, it's hard to combat that. So, you know, again, there's a tremendous gap. Part of why I do what I do is that there's a tremendous gap between what the science is and what that public perception is. And you're absolutely right that young people, that's where they're getting the perception. They're plugged in to these, you know, social media sites, and that's where a lot of these myths are perpetuated. But I have not done that kind of research.
Right. I just wanted to say that we work through the lens of the public health model, and Kevin knows that one of the biggest protective factors is parents. And in longitudinal surveys, kids have told us, nationally, locally, that 2/3 of kids say losing their parents' pride and respect is a reason they didn't smoke marijuana or take other drugs. And kids are 50% less likely to use if they've learned about the dangers of drugs from their parents. My teenagers would never tell me that. But kids will tell me that I work with, and families, and the surveys show that parents are a protective factor. So I was happy to hear Kevin say he's an accomplished scientist and a speaker all over the world. He's saying parents talk to your kids, tell them about the dangers, be there for them. And as communities, we're trying to do the other things, you know, have the messages come from many different places and working together. So the social media is unbelievable. Your kids developmentally in adolescence won't tell you they want to be with you or hang out with you, but what we know kids tell us is they want to spend time with you. So have those conversations and become a person that does share the science. And, you know, hug them. Tell them you care about them. I always have said our goal is not to make anyone afraid. It's to make you aware. And we hope we've done that tonight, to make you aware that there's science and facts that can back up the impact of substance use on the developing brain. That being said, you're prepared to have those conversations and you're not alone. But you do make a difference, although your kids might not tell you. They tell us. You're important. So if you're stuck on what to say or what to do, we have some experts. But please understand that developmentally, it looks like they push away and we're supposed to, but they do want us involved and they do want to hear from you. So I just had to really point out that I appreciate Kevin as a scientist talking about parents as a protective factor.
So I'll
Do
be
you-
up here to take any more questions that you have, but I think we're
Right.
out of time, essentially.
Thank you. Thank you for
Thanks.
all of you, and thank you to Kevin. Thank you to John.